Welcome back. This is video number 15, drug-coated balloon, basics. Is there rule in this patient with chronic kidney disease in which there is mid-LED bifurcation, small vessel diameter? And in this patient in which there is lesion in the distal half of the LED, in which the IVUS showed a moderate lesion in the ostial LED and left mean. And these are the points to be discussed. What is the rationale for drug-coated balloon? There are two main arguments against drug-coated balloon dilatation in de novo coronary artery lesions. First, it is still difficult to imagine treating a lesion without a stent. European guidelines 2018 do not recommend its use for treatment of de novo coronary artery lesions. The second argument is there is a legally high number of acute vascular occlusions. Although in SCAR registry and basket small 2 trials, there was a lower rate of target lesion thrombosis. Drug-coated balloons appeared in the European market in 2007 with two main arms. A mechanical arm, which is linked to balloon dilatation, before the drug-coated balloon insertion, while biological, in which there is drug release in the vessel wall through the drug-coated balloon. So lesion dilatation is for mechanical dilatation and preparation for drug release. Drug delivery balloon is only for delivery, not for dilatation. So this provides a larger contact surface with the vessel circumference with prolonged contact time, leading to more homogeneous drug tissue transfer with proper concentration, leading to sustained release of the drug, leading to slow positive effect process in the media and adventitia. If compared with drug-eluting stents, in cases of drug-coated balloon, there is homogeneous drug distribution on the vascular wall, while in stents, about 85% of the wall is not covered by the struts, leading to an inhomogeneous drug distribution. As a healing process to vascular injury to stents or to PTCA, neointimal hyperplasia with proliferation and migration of the vascular smooth muscle results in decreased lumen area. This is one of the main causes of early restenosis post-PCI or post-PTCA. With this more uniform drug distribution with drug-coated balloons across the wall of the artery, there is less hyperplasia and complete reendothelialization of the struts. This is highly considered in cases with small vessel diameter arteries, since there is same degree of hyperplasia yet with higher percent of instant restenosis, or cases with high degree of hyperplasia, healing process, and instant percent stenosis, as in cases of diabetes. The most common cause of late instant restenosis is instant neoatherosclerosis. One of the causes of this neoatherosclerosis is chronic inflammatory reaction to the metal, polymer, or drug entrapped in the struts. This leads to macrophage recruitment and new atherosclerotic plaque development. This process is an accelerated form, not the case as in the native arteries, with high incidence of stent thrombosis due to thin fibrous cap. Repeat stenting on the in-stent restenosis adds an additional metallic layer that may replicate the cause leading to in-stent restenosis. So leaving nothing behind with drug-coated balloon solves the problem. There is no metal, nor polymer, nor extracellular drug. Since nothing left behind, International Consensus Report on Drug-Coated Balloon recommends to reduce depth duration down to 4 weeks after balloon dilatation in native vessels and in patients with chronic coronary syndrome. Shorter duration is highly proposed in patients with high bleeding risk. With coronary vasomotor disorders, there is impaired ability to adequately adjust coronary blood flow to oxygen demand leading to myocardial ischemia. This includes spontaneous spasm or impaired vasodilatation. It can occur at the epicardial level and the microvascular level of the coronary circulation. Both the proximal and distal segments to the stents dilates in response to exercise and more to sublingual nitroglycerin. Obviously, this is impaired in the stented segment. Vasomotion with no vulnerability to vasospasm is preserved in segments treated with drug-coated balloon due to absence of metallic caging. Endothelial function in these segments is preserved. In segments treated with drug-coated balloon, there is enlargement of the total vessel area. This is followed by an increase in the vessel's lumen area. This is very similar to the compensatory vessel enlargement in the early phase of atherosclerosis and is explained by accumulation of paclitaxel in the adventitia. This is documented in many studies, so a non-stent-like result can be accepted initially, yet with later lumen area gain. With stent treatment, there is prevention of elastic recoil and superior primary lumen gain, yet with loss of lumen over time. This benefit also applies to the ostium of the side branches in the setting of bifurcation lesions. Also, with paclitaxel drug-coated balloon, the more the initial gain after balloon dilatation, the better the result in late lumen loss, especially if IVUS or QA guided. This late study in 2024 showed that extensive medial dissection after drug-coated balloon angioplasty was associated with higher late lumen occurrence in native coronary lesions. Better distribution of the drug may explain the correlation. While in cases of plain balloon, the more the gain, the more the loss in the lumen area later, even if IVUS or QA guided. In this recent Ultimate 3 trial, 7 months follow-up after IVUS guided PCI was associated with less late lumen loss compared with angiography guided PCI. Possible explanation is that preparation with IVUS guided group used approximately larger balloons than in the angiographically guided group. Most probably, this is also applicable if the non-flow limiting dissection is present after angioplasty before drug-coated balloon dilatation, not just after. Other potential indications for drug-coated balloon is in cases where stents are not encouraged with high complication rate, as a large number and length of stents with high incidence of in-stent restenosis, acute coronary syndrome aneurysm with fear of malopposition, myocardial bridge or tortuous artery with high rated force or shear stress, and other indications. These detailed cases are later discussed in Part 2. Regarding the drug used in drug-coated balloons, paclitaxel is still the drug of choice, with a typical dose between 2 to 3.5 milligram per millimeter square on the balloon surface. In some preparations, the drug is mixed with a hydrophilic contrast media to increase its hydrophilicity, leading to a more rapid release of the drug in the first seconds of inflation. This leads to a far beyond concentration of the drug in the vascular smooth muscle cells. Paclitaxel binds irreversibly with microtubules, resulting in a long persistence in the vascular cell at least 6 months, with very low systemic exposure. Sequent Please device with this matrix formulation is the most studied device in trials. In the Egyptian market, the most common used drug-coated balloon is Essential Pro device with no additives added. Sirolimus is now used in new drug-coated balloon designs. In comparison with paclitaxel, it shows low lipophilicity, so it is entrapped in protective lipophilic package to allow for penetration into the arterial wall during balloon inflation. It shows more hydrophilicity, so there is no need for matrix as with paclitaxel in some designs. Wider therapeutic window, cytostatic mode of action, so with better increased anti-restenotic effect compared with the cytotoxic effect of paclitaxel. In a recent clinical randomized trial comparing sirolimus with paclitaxel, there is no difference after 12 months. There is no class effect of drug-coated balloon. And there is ongoing Transform 2 trial comparing sirolimus drug-coated balloon versus new generation drug-eluting stents. Regarding the steps needed for drug delivery. This algorithm is for treatment of de novo lesions according to the International Drug-Coated Balloon Consensus Group, 2020. It is based on expert opinions by operators with extensive drug-coating balloon experience. The length of the segment for preparation and drug delivery is the length of the lesion plus at least 2 mm proximally and distal to it. First step is pre-dilatation. Start with semi-compliant balloon angioplasty, 1:1 ratio, 8 to 10 atmosphere to reach the nominal diameter, as higher pressures may not result in equally applied force. The time and the number of inflations to reach the target ratio is according to the manufacturer. This is followed by non-compliant balloon. Size is 1:1 ratio with higher pressure up to 25 atmosphere for more equalized inflation with greater radial force. Time and number of inflations to reach the target ratio is according to the manufacturer. Scoring balloon dilatation is a good option. In this retrospective analysis of 278 de novo lesions, scoring balloon dilatation showed higher prevalence of residual diameter stenosis less than 30%, with superior rate of optimal angiographic results about 50% more. This is reflected clinically in ISAR Desire 4 trial, in which there was better long-term results regarding the incidence of MACE and lesion revascularization. In special situations, cutting balloons and calcium debulking strategies may be preferred. After preparation, assessment is done. If the angiographic result is unclear regarding the stenosis grade or the remaining type of dissection is unknown due to delayed contrast clearing, as an example, other devices should be considered. Imaging with IVUS or OCT is useful, yet presence of microthrombi or vasospasm may result in a small minimal lumen area, which may be misinterpreted as inadequate lesion preparation, leading to more aggressive, unneeded lesion preparation. Regarding functional assessment with FFR, despite absent ideal threshold after angioplasty, FFR of 0.8 may be a good threshold for guiding angioplasty. If the assessment showed an acceptable result, according to the DCB consensus group, after full 1:1 balloon dilatation of the lesions, it is defined as residual stenosis not exceeding 30%, flow limitation up to grade 3, either due to thrombus or flow limiting dissection. According to this study, the target lesion revascularization rate was lower from 35% to 20% when lesion preparation fulfilled the full DCB consensus criteria. The difference was even more pronounced in a study including 309 lesions. After 2 years, target lesion revascularization was only 8.3%. If the residual stenosis was less than 20%, balloon diameter was at least 90% of the stent diameter, and inflation time was more than 60 seconds. After only partial compliance, the lesion revascularization rate increased about the double. After an acceptable angiographic result, the third step is drug-coated balloon dilatation. The target is 1:1 balloon-artery ratio. No partial deflation after a few seconds with dispersion of the drug. No overinflation with a decrease in concentration of the drug in the vessel wall. The device is just for delivery. No underinflation with a decrease of diffusion of the drug to the wall. Sufficient inflation time and pressure is a must. Need prolonged contact time according to the manufacturer recommendation, at least 30 to 60 seconds. Some preparations release most of the drug in the first few seconds, yet complete inflation time. A very short delivery time is essential. To avoid drug loss during balloon preparation, caution is considered when handling a drug-coated balloon, as some brands may shed drug and carrier when touched or after contact with liquids. Prevent wetting, touching, or contact with other materials. Dye flushes, not injections. Proximal lesion preparation or strut dilatation, not to waste drug when in contact with the lesion. The fourth step is post-drug-coated balloon dilatation assessment. There is very low incidence of lesion recoil, flow-limiting dissection, leading to drug-eluting stent implantation. The drug-coated balloon only delivers the drug. If there is recoil or dissection, mostly it will be after lesion preparation. What if the assessment after lesion preparation is unacceptable, with unfulfilled criteria of an acceptable result? DAS is used as a bailout since residual stenosis or recoil will have high incidence of restenosis and associated cardiac events, and flow-limited dissection will cause ischemia and or artery occlusion. To ensure optimal drug delivery to the lesion and diffusion across the cell membrane, avoid or delay performing any post-dilatations after angioplasty, as in cases of bifurcation lesions. Clinical indications for drug-coated balloon dilatation is either documented or rapidly evolving and will be discussed in later videos. In summary, drug-coated balloon technology is rapidly evolving. Awareness of its benefit and role is important, although some authors may deviate from the points discussed in the old consensus, yet the crucial point is optimum lesion preparation. A good plan for all scenarios is important before decision. For example, if failed preparation, is stent deployment in the lesion acceptable or surgical consultation? And this is the end of the video. Thank you for your attention and waiting for your feedback.